So tonight I will be presenting on communities of practice and complexity leadership theory. And my topic is about a community of practice for knowledge translation, which involves some of the work I do in the Faculty of Medicine at the University of Alberta. Knowledge translation, or KT, is a paradigm, and the World Health Organization describes it as a paradigm. It's a paradigm that involves processes, methods, and practices for helping to move health research evidence into clinical practice and health policy, programming, and services. So it involves things like behavior and organizational change management, information and intervention design, impact evaluation, and system scale-up. KT encompasses knowledge synthesis, such as systematic reviews and meta-analysis, dissemination, and implementation science. And KT has its own evidence-based scientific methods and prescriptive practice. So here's the Canadian Institutes of Health Research definition of knowledge translation. They describe that knowledge translation is defined as a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians, provide more effective health services and products, and strengthen the healthcare system. This process takes place within a complex system of interactions between researchers and knowledge users, which may vary in intensity, complexity, and level of engagement, depending on the nature of the research and the findings, as well as the needs of the particular knowledge user. So, in other words, KT is about putting health research evidence into the hands of users and helping them to use it. And I should say here that although my presentation tonight talks about health system professionals as end users of health evidence, end users could really be anyone, including the public, and a lot of my work at the U of A extends into this space as well. But my presentation tonight focuses on health system professionals as end users. So here are a couple of KT frameworks. This first one is the Knowledge to Action, or KTA cycle, which is commonly used in North America. And here's another one that was developed in Australia. And then there's some others that are widely used in Europe and Africa. But these are two that I've used quite frequently and like working with. And they actually have a really nice alignment to design-based research, which is something that we looked at in our 802 course. I won't talk in depth about KT frameworks at all in my presentation tonight, but if anyone is interested, I can share more information at another time. Although knowledge translation is situated within health-related areas, I do think it could have much broader disciplinary applicability. So knowledge translation has emerged over the past 20 years or so in response to significant delays in the uptake of health research evidence into clinical practice, policy, programming, and services. The estimated average is about 17 years, but the range is estimated to be between 10 and 30 years. Now, think about that for a moment. It means that a lot of health research is taking almost 2 decades, almost an entire generation, before it starts to benefit patients. And it also means that billions of dollars spent on publicly funded health research has been ineffectively invested. So this is a really important social issue. And knowledge translation arose in response to this issue. However, complex systemic barriers still persist, and one of these barriers is a lack of KT training opportunities. KT has been advanced across many health-related disciplines by academics who have a research interest in knowledge translation. And in Alberta, there's actually a bit of a hotbed of KT experts. There's a number of Canada Research Chairs in Knowledge Translation who are located in Alberta and who have expertise in KT science and methods. But there's little in the way of formal KT training in degree programs or accredited courses. So, with few exceptions, KT training is typically informal continuing education or professional development opportunities, such as workshops or short-term non-credit courses. So what this means is that graduates, such as public health epidemiologists who come from pure science backgrounds, they're entering Alberta's health system to take on professional roles in research, implementation, and evaluation. In other words, evidence to practice facilitator roles. But they lack the core skills in these process and programmatic areas. And for those who do access KT training through these informal routes, many have difficulties transferring their learning back for application in their workplace context. So as a result, there's a lot of research, implementation, and evaluation work being done in Alberta's health system that is not methodologically rigorous and that produces evidence that is not sound. And it's this unsound evidence that's being used to inform health policies, programming, etc. And also scaling up of pilot initiatives up to system level application is something that's also difficult because of this. So there's a lack of training opportunities, and in Alberta, there's also been a long-standing separation between academic researchers and health system professionals, as well as a lack of collaboration and consultation. So that's another part of the issue. Now, the organization that I work with, it's called the Alberta SPORE Support Unit Knowledge Translation Platform, or SPORE KT for short. And SPORE stands for the Support for Patient-Oriented Research. And my SPORE KT group is part of an Alberta-wide SPORE unit that encompasses other groups with specific expertise, such as data, patient engagement, and patient-oriented research methods. The Alberta SPORE is part of a distributed Canada-wide SPORE network, which is funded through the Canadian Institutes of Health Research. And there's a SPORE unit in each province and territory with matched provincial partnership funding. And in Alberta, this joint funding comes through Alberta Innovates. My group, SPORE KT, has expertise in knowledge translation. We have a mandate for capacity building in KT in Alberta, and this includes providing formal and informal opportunities, training opportunities. Learning through collaboration is an important aspect of this, but a needs assessment that was undertaken a couple of years ago observed that a shared central space and mechanisms for collaboration is something that has been missing. So it was identified that establishing a community of practice for knowledge translation would be a way to move forward to create this shared central space, to bring together academic researchers and health system professionals as a means of capacity building. Communities of practice have become a widespread approach for continuing professional learning and development within many health disciplines. So the KT Alberta Community of Practice was launched in November 2017, and efforts so far have been to engage an initial base of members and to work at identifying a common question or problem around which the community of practice could coalesce. But there had not really been any thinking about it from an educational perspective. So this assignment has provided a chance for me to do a lot of this thinking. Okay, so the idea of a community of practice is premised on situated cognition theory, and emerged from the work of anthropologist John Lave and sociologist Etienne Wenger, who explored how micro-level learning interactions and macro-level practice norms in apprenticeships were mutually constituting. And my understanding of it is that a community of practice coalesces as individuals interact to resolve a shared question, problem, or issue within a domain of inquiry or a series of focus domains embedded within a broader domain of inquiry. Typical community of practice structure includes a core of leaders who are typically domain experts or champions, as Wenger calls them, and these individuals lead or guide the inquiry that takes place within the community of practice. There are also core members who take on the management and administration of the community of practice, and these may also include core leadership. And then there are members who have various levels of affinity to the community of practice and variable levels of engagement. And these members may include individuals who are situated at the periphery of the community of practice with little or no expertise. And they engage with the community of practice either to gain expertise or to gain limited skills and knowledge that they may use elsewhere. Leadership may be characterized by some fluidity, as individuals with topic expertise take on responsibility for leading or guiding the inquiry opportunistically, and core leadership is regenerated as members move from the periphery towards the core as their expertise develops. So practice is advanced collectively within the community of practice as the members engage in domain inquiry through the mechanism of a question, problem, or issue to resolve. And it's a sort of applied inquiry. And in this way, these three elements of the community of practice, these three being the community, the domain, and the practice, they're mutually constituting and serve as co-management mechanisms for the community of practice. One of my group, Sport KT's objectives for establishing the KT Alberta community of practice is to develop a learning health system in Alberta. The Agency for Healthcare Research and Quality describes that in a learning health system, internal data and experience are systematically integrated with external evidence, and that knowledge is put into practice, and include leaders who are committed to a culture of continuous learning and improvement, continually assessing outcomes to refine processes, and training to create a feedback cycle for learning and improvement. As a learning health system, the KT Alberta Community of Practice will connect academic researchers who are methodological experts with health system professionals who are real-world application experts to enable this type of synthesis. Cross-context exposure like this may also help to advance KT science and prescriptive practice through information or feedback from real-world contexts within Alberta's health system, such as operational and political pressures, and prescriptive practice may be revised to better align applications of the science in response to these realities. For health system professionals, this convergence helps to optimize the relevance, practicality, and implementation ease of KT science and prescriptive practice, situating the learning of core KT skills and knowledge within their workplace contexts. While the KT Alberta Community of Practice provides an informal learning environment, it can also be leveraged as a pathway or mechanism for developing and delivering formal training opportunities that are more formal in nature. And what I'm working to develop in my work with KT Alberta, and this assignment has helped me to get a start on this, is a framework for a series of CMOOCs, connectivist MOOCs, which will be developed and delivered through the community of practice to provide a learning ecosystem that encompasses more formalized pedagogy than the community of practice would alone. A CMOOC or series of CMOOCs may also provide more formalized structure that helps to reinforce and sustain the community of practice. So CMOOCs are different than the large MOOCs or extended MOOCs that we're probably all familiar with, and these are the ones that are offered through providers such as Coursera and edX and others. CMOOCs are premised on connectivism, which is a very different philosophy, and tend to engage fewer learners. They emphasize collaborative inquiry and interaction. They involve problem-based learning. What are some other characteristics? They have a decentralized locus of control and a focus on learner-generated content and contexts, and learner-centeredness. And the facilitators are facilitators rather than sage on the stage or one-way video lectures, and so on. So you can get the idea of why a CMOOC might be a really good match for a community of practice. Because of their context-led and problem-solving pedagogy, CMOOCs are particularly appropriate for providing authentic professional learning experiences and have been effectively implemented through community of practice infrastructure elsewhere. CMOOCs can also have a quite agile structure that enables curriculum to be designed and developed quickly in response to emergent issues, changing evidence and practice, and professional development needs such as just-in-time learning. So my thinking is that using a CMOOC format in conjunction with the KT Alberta community of practice will allow for designing a generic framework to scaffold KT science and prescriptive practice advancement, as well as community of practice leadership emergence through the exploration of opportunistic questions, problems, or issues across a variety of stakeholder contexts. I can't say that word. And the community of practice leadership will serve as a CMOOC. The community of practice leadership will also serve as CMOOC facilitators matched to their expertise. A KT Alberta CMOOC also has the potential for broader linkages that could help address the training needs of stakeholders. So, for instance, the CMOOC could be embedded within 4-credit in-person courses in those graduate programs that are often used as recruiting grounds for health system professionals. And these are programs such as a Master of Public Health or a Public Health PhD. And what this integration would do is provide for earlier training intervention before these graduates enter their health system roles. So they'd be coming into the health system already having those core competencies. And there's also been some examples of CMOOCs being integrated across multiple in-person courses at distributed sites. And this allows for collective learning to emerge from a more heterogeneous engagement while simultaneously explored within distributed local contexts. I really can't say that word. I've also had the idea, and the training and professional development program I manage at the U of A is far broader than the community of practice and the CMOOC ideas. So one of the ideas I've had is that the CMOOC could be utilized to satisfy pieces of a formal KT certificate program that I'm developing, which utilizes a flexible competency-based micro-credentialing structure. And here's just a picture of the concept I have in mind for this micro-credentialing. And the CMOOC could fit in nicely to any of the pieces that are shown here. Another initiative I'm developing is a KT Open Educational Resources Repository, which, among other things, could provide materials for use with the CMOOC. And it could also be populated by linking in the knowledge products that are collectively produced by learners in the CMOOCs. The KT Alberta Community of Practice currently uses Twitter and has a website through Squarespace, which is a horrible platform, and I would not recommend Squarespace. But anyways, for the CMOOC, the use of open access online platforms such as Twitter, Wiki, and WordPress, for instance, could provide rich data for use in a project study that combines cyber ethnography and discourse analysis. And then supplemental data could also come from the results of a process evaluation that would be undertaken by SPORE KT and which would include qualitative interviews. Okay, so thinking about all this, complexity leadership really seemed like it might be the best fit with the idea of the community of practice. I considered distributed leadership, but it was really the process of complexity leadership that I felt aligned well with the processes of a community of practice and the idea of the learning health system. So I'll explain here what my rationale was for that choice. In complexity leadership, leadership emerges from processes and interactions that take place within the system rather than residing within individuals. Leadership is situated within process-based functions, and Hazy and Ulben have identified 5 different types of functions. These include generative, administrative, community building, information gathering, and information using. And these leadership emerges through various mechanisms enacted by individuals and disparate parts or units comprising the system towards these different leadership functions. The concept it seems to me to be one of cyclical and mutually constituting system whole and system parts. And here, this arrow in this image should really be going in the opposite direction as well. One of the important concepts in complexity leadership is entrainment, which Hazy and Ulben describe as being the limiting effect that norms have on the freedom and variation of an individual's choices and actions within a system. And norms emerge from feedback loops among the whole system, its disparate units and individuals. Patterns that arise from the fine-grained interactions among units and individuals situated within local contexts within the systems. These patterns, if they are successful, may give rise to coarse-grained properties that may become norms, and then these norms become prescriptive for fine-grained interactions which limit variation. And this is entrainment, and entrainment can be used for achieving system objectives. So these complexity leadership functions and complexity mechanisms generally align to the iterative learning processes that take place within a community of practice and may be enacted through a community of practice learning ecosystem, as I have described. Regarding the KT Alberta community of practice, objectives are advanced through norms, such as KT science or practice, and the core KT competencies regarding how to, for instance, determine which data to collect for an evaluation of a pilot program. These norms emerge from the coarse-grained properties, which are the everyday organizing patterns and regularities. For example, an approved evaluation data collection protocol at a local clinical site. And these coarse-grained properties emerge from fine-grained micro-level interactions, such as how staff might approach patients or colleagues for data collection, or the way in which a questionnaire is administered to patients. Regarding the KT Alberta community of practice, I've talked about it involving individual leaders, which is not typically a characteristic of complexity leadership. However, as a component of a community of practice, leaders can be viewed as serving as a mechanism through which fine-grained interactions are carried out. KT Alberta community of practice leaders are subject to entrainment along with other community of practice members, while simultaneously having a role in collectively negotiating norms through fine-grained interactions within their own local contexts. So, for example, at a clinical site or a research institution, as well as with other KT Alberta community of practice members. So, for example, a KT framework may be adapted for practicality when it's applied in a real-world context to account for budgetary and staffing limitations at one local clinical site. In this scenario, the framework retains its methodological rigor, and also may be transferable to other local clinical sites. The observations, experiences, or measured impacts from the adapted application of the framework at the local level may be fed back through the system if they are successful, and may also influence an evidence-based change in KT science and prescriptive practice if validity and generalizability of that adaptation can be determined. So here is an illustration of how complexity leadership functions and complexity mechanisms map to examples of KT Alberta community enactments. So in a nutshell, my specific reasons for selecting complexity leadership as the leadership approach for this KT Alberta Community of Practice initiative include the distributed nature of the complex system involved, encompassing diverse learning contexts and loci, the iterative processes through which communities of practice coalesce and through which community of practice leadership emerges, the project goals of affecting both individual local site change and as well as systemic level change, the project goal of affecting entrainment through a confluence of KT science and prescriptive practice that is under continuous revision across diverse stakeholder contexts. And finally, the overarching project goal of providing KT training that will enable learners to collectively affect entrainment in clinical practices across Alberta's health system. However, there's one additional reason, which I think is perhaps the most important, and this reason is the separation between academic researchers and health system professionals in Alberta. Separation of these groups impedes all the identified complexity leadership functions and complexity mechanisms. Information contained in norms and coarse-grained properties, these are the KT science and prescriptive practice, is not applied through information use in local sites, where information gathering through fine-grained interactions among health system professionals and the health system would take place to feedback through or ratchet to inform coarse-grained properties and norms, through which refinements in KT science and prescriptive practice may be negotiated via the community. So the KT Alberta Community of Practice, in providing a shared space for academic researchers and health system professionals to interact, helps to mediate this separation and provides for the enactments or mechanisms of the cyclical and mutually constituting complexity leadership functions to occur. This provides opportunities for both academic researchers and health system professionals to learn from each other and to co-create the learning content and processes. And through this, a shared identity emerges as community. For example, shared identity is formed through academic researchers and health system professionals collectively negotiating revisions to KT science and prescriptive practice, premised on the coarse-grained properties that emerge from fine-grained interactions. So that is my presentation. My paper, I've already posted it in the forum, along with a couple of questions to kick off the discussion. And I welcome any questions here or in the forum. And thank you very much.